Medical professionals of Reddit, what mistake have you made in your medical career that because of the outcome, you've never forgotten? So, once as a tired medical resident, I was called to the ER to admit someone at like 3 a.m. This bonehead had gallbladder removed a week ago and now had a surgical site wound infection. I asked if they'd taken their post-op antibiotics they were prescribed, and they weren't sure. I was getting more and more frustrated with this dumbass preventing my sleep when I decided to use a pregnant pause interview technique and just shut up. This usually results in either awkward silence and the patient saying, what the hell, doc? Or awkward silence followed by some useful deep revelation. In this case, the guy hung his head low, looked at his feet through unfocused eyes, started to sniffle while his halting voice cracked and said, "I can't read. Never could. Didn't know the instructions they wrote down for me and didn't know I had medicine to buy. I didn't ask them because I was embarrassed." And let me tell you, illiteracy haunts rural and urban places in most countries. Those folks aren't reading this, and they depend on our patience and understanding and acceptance to detect and bridge that vast communication gap. That's what stuck with me. Next story. When I was a new paramedic, we were called to a house for an unknown problem. We arrived and found our patient unresponsive but breathing on a bed. A friend of his found him after he hadn't returned his phone calls and they were going out to do something that day, and he found it weird that the guy hadn't called him yet, so he had gone to his house to investigate. The patient didn't have any pill bottles laying around, and his friend didn't know anything about the patient's medical history, so I loaded him up into the ambulance and started transporting to the hospital. Started an IV, did an ECG, drew blood work, the whole workup, get him to the hospital, and the first thing the nurse asked was, "What was his blood sugar level?" Oops. Forgot to check it. Turns out it was incredibly low, which is completely treatable and probably wouldn't have required transporting him to the hospital if corrected on scene. Every patient gets a blood sugar check now. Edit. Yes, the patient probably would have been transported anyway, but I still would have initiated treatment on the scene and fixed the underlying problem. But this wasn't really the place for a discussion of the management of hypoglycemia in the pre-hospital setting. That's for REMs. Next story. This is something a little narrower to my field than a lot of these. I work in palliative care, and in the fall, I sent a patient home to see if he could die there instead of in hospital. We weren't very hopeful, but thought it would be worth a try. To no one's great surprise, even his and his wife's, he ended up coming back a couple of days later for whatever reason. I readmitted him since I knew him. I knew he wanted to be a DNR, do not resuscitate, and I wrote it on my note, but I didn't refill out the hospital paperwork. The next day, I go to work to discover he'd been coded and was on a ventilator in the ICU. Instead of passing peacefully, his wife had to make the decision to turn off life support. My entire job at the end of life is to ensure as good a death as I can. And in one simple omission, I effed that up royally. Next story. Pharmacy technician here. I once was much too stressed and I was rushing. Instead of prednisone 5 milligrams, I used prednisone 50 milligrams. The pharmacist checked it and didn't catch it, but I realized when I was putting my stock bottles away. Luckily, it hadn't gone out yet, so I fixed the mistake and vowed to be 100% dedicated to one task at a time. A few months later, somebody made the same exact mistake but did not catch it, and the patient ended up in the hospital for a few months. Prednisone is a steroid. Next story. I do HIV testing, and once I showed up to work super tired because I couldn't sleep the night before. This guy comes in for a test, we go through the pre-counseling, and then I tell him to step out for a few minutes while the results come up. Once he comes back to get his results, I tell him to take a sit, and the first thing that came out of my mouth was, "Your results are positive." And then I saw the look on his face, and that's when I effed up and I said, No, I meant to say negative. I almost gave the guy a heart attack. Next story. This isn't so much a medical error, but a time I feel that I failed my patient. I was on my first clinical rotation in a rural emergency room, and a woman came in with a miscarriage, her second one. While we were talking, she mentioned she was new to town, didn't know anyone, and her husband was away for the weekend. When we told her the diagnosis, her eyes became very teary, and then we left to make arrangements. The doc didn't say he was sorry for her loss or comfort her in any way, which I instinctively wanted to do. When I went back into her room to give her appointment time, she was in pieces. It really gets me. The 5 seconds it would have taken me to say those words, put a hand on her shoulder, call someone, or just offer some tissues. Anything, but I didn't do it. Instead, I let my fear of not knowing I would be showing too much emotion or slowing down the doctor stop me from being human. The silver lining is now I do what my gut tells me. I've soothed babies from exhausted parents, picked up crying family members off the floor, and even discussed comic book heroes with kids getting stitches because that's the kind of person I am. And doctor, that I want to become. Next story. A couple, I'll tell two here, a funny one and a non-funny one. So I was working as a pre-registration pharmacist in a community pharmacy based in a supermarket. A boy and a girl come in, nervous as hell, and step up to the counter. They're teenagers, probably 17, 18 or so. In the UK, the age of consent is 16. The boy asks, "Can I have some condoms, please?" And I'm serving, and we keep the condoms at the counter. They come in packs of 3s, 10s, 20s, so I smile, trying to be reassuring, but I need to know what they want. So I say, "Sure, what size?" The boy turns bright red, but his girlfriend nudges him, and he starts estimating with his hands, about this long? And then the second story I'll never forget, I was in a cancer clinic doing follow-ups. I had just effed up a drug choice. I was under supervision, so it was fine, and wanted to try and ask something smart to the oncologist. So we're in a consultation with a woman who'd had a mastectomy, and I asked the probability of recurrence of the cancer. And oh man, was that stupid. Because the oncologist then had to answer and probably be very conservative and scare the crap out of the patient. That really destroyed me. I felt like a total a-hole. Next story. I'm a lab tech and used to work in histology when I was new. I got a skin biopsy specimen, and that day I was embedding, basically putting the fixed tissue into wax so it could be mounted on a cutting block to slice 3 micrometer sections for staining. And it's very important what side you place down based on how it was cut out of the body. Well, I messed up and placed it sideways instead of down. The person cutting the tissue couldn't tell and ended with me cutting through the tissue. This was a problem because the patient had skin cancer and they were looking at how far it had spread. Since it was cut too deep, they couldn't see the edges anymore. This means the doctor had to cut a bigger piece of skin off to be sure they got it all. That's when I found out it was a skin biopsy from the patient's nose. The patient then had to have a bigger, potentially unnecessary piece of skin from his face cut off because of me. I was horrified and learned my lesson that day on how important it is to be certain of embedding technique. Next story. I'm a cardiac cath lab tech at another hospital. I've been in the medical field for almost 6 years. I was being cross-trained in computed tomography recently and was thrown into my first night shift by myself after a quick month of training. I had a script I spoke every time I would hook someone up to our power injector for a contrast study, the weird stuff that makes you feel like you pee all over yourself. The injector I used in cath lab is a hell of a lot bigger and scarier than this little thing, but they are still dangerous as hell. I also don't worry about blowing IVs in cath lab since we normally go through a much tougher femoral or radial artery. We then do 2 test injections of saline, one by hand and one by the injector to make sure the IV is patent and will tolerate the injection. 99% of the time this works and everyone is hunky-dory. If it blows now, the body will simply absorb the saline and you might get a bruise, so no big deal. But this time, however, the IV blew right at the beginning of the contrast injection. Your body can't absorb contrast in this fashion, and the little pressure waveform on the injector remained normal looking. She didn't once cry out or scream as I injected 100 cc's of low-donated contrast agent into her forearm, and I only noticed something was off when I started my scan and saw 0 contrast in her torso. I aborted the scan, thinking the IV blew outside of the patient, walked into her quietly sobbing inside of the machine with an angry swollen arm about the diameter of a grapefruit. I pulled her out, wrapped a hot water-soaked compress around her arm, held it over her head, and rushed her back to the ER. I find out later she had to go to surgery for it and has long-term nerve damage from the compartment syndrome she suffered. I've had people die on my table. I've been on a code team for my entire term in cath lab. I respond to code blue/cardiac arrests, and I see death and mutilation every day at my level 1 trauma hospital as the night tech. But this one stuck with me since I felt I was directly responsible for it despite being cleared. It caused me to change my whole approach when doing my contrast studies. I tell people to scream bloody murder if their arm does more than burn now when I inject. Insult me, throw a shoe at my window, hit the big red emergency button on the wall, anything, so I don't disfigure someone again when my safeties fail and my machine lies to me. Sorry for the run-on. I'm tired after a 16-hour shift. Next story. 16 years ago, when I was a medic in the military, this one Marine who came in for physical therapy seemed overly depressed, more so than usual. He had bad nerve damage, amongst other injuries, and when we would touch his leg, it felt like someone was touching him in the back, he said. I was more focused on the therapy that day and was excited he was making progress, though. He didn't seem happy about the progress and made a comment about how it won't matter. I also recalled when he left, I said I would see him next week, and he didn't say anything and just left. He took his own life over the weekend. I still wondered if I had paid attention to his comments and not had dismissed them as having a bad day, maybe he'd still be alive. Then again, mental health issues were still seen as a defect when I was in, so would he have even accepted mental health treatment? Sorry for rambling, but I now pay attention to friends' mood swings and signs of depression. Just wish I had done the same 16 years ago, though. Next story. I am a nuclear medicine technologist working in a pet department. I deal mostly with cancer patients. Prior to exams, I'll ask the patients why they are having the test done and for any other vital information. One day, a female patient told me she found a lump, had a mammogram, a biopsy, and it turned out to be stage 4 invasive ductal breast cancer. Having confirmed the information I had on my sheet with the patient, I made the mistake of saying, "Sounds good," to which she replied, "No, it's actually pretty effing terrible." And she broke down in tears. I will never say "sounds good" again when a patient tells me his or her diagnosis. Next story. I one time said, "Wow, that's really cool," after listening to his LVAD for the first time. That is a left ventricular assist device for heart failure that continuously circulates in a parallel circuit to the left ventricle to keep the patient alive. And he joked and said, "It's really cool if it's not inside you," and I said, "Oh, yeah, right. I meant the sound and the technology, but yeah, I'm sorry about that." He was a jokester, very happy, but it did make me think twice before opening my mouth again in certain situations. It was a damn cool piece of technology, but the patient's interpretation of your words is paramount. Next story. Not really a serious outcome, but I'll never forget my first mistake as an EMT. Patient was in the back of the ambulance in a gurney, duh. He required oxygen, he's human after all, via cannula, little nosy things. Normally, the gurney O2 tank is much smaller than the house tank on the ambulance, so we generally switch over the gurney to the ambulance tank. So basically, there is now a small hose attached to the wall of the ambulance that feeds the patient delicious oxygen into his nose. This being my first time, I forgot to switch back the hose to the gurney, and upon removing the gurney from the back, I essentially choked the crap out of his face when the hose tightened up. Poor guy, he thought he did something wrong. I explained to him what had happened, and then he laughed about it. Found out later, he still tried to sue. Oh well. Next story. I'm a hospitalist, an internal medicine doctor that specializes in hospital inpatient medicine. I had a lovely but truly unfortunate lady. She was in her late 40s and had a metastatic breast cancer. It had spread to her brain and actually to her intestine, causing persistent bleeding. She was in and out of the hospital for about 2 months. I knew she was dying. Her oncologist knew. I began talks about what to do if she got sicker and was nearing death, and she wanted everything. I was off and my partner took over. She eventually got sicker, which I 100% expected, was bleeding again from her tumor essentially coated, was placed on a ventilator and sent to the ICU. The thing is, it should have never gotten that far. I should have made her DNR. She had no hope of survival. She should have had a peaceful death. Instead, she was intubated and died in the ICU. Families and patients get mad at me when I try and discuss end-of-life goals, but this is the reason I do it, despite patients getting ridiculously pissed at me for trying to address this important issue. Next story. I was still a new EMT and had a new paramedic as a partner. We got a call of a man with no pulse. We arrived and find a 350-ish pound man in the middle of a waterbed, no pulse. So the new paramedic did a quick look with the paddles and decided to shock. The shock creates a muscle spasm and set off a series of events which led to the patient being wedged between the waterbed mattress and the frame. It was impossible for two of us to unwedge him, although there was a brief discussion of cutting the mattress and letting all the water out. So, never shock someone you can't lift on a waterbed. You know what's crazy? In all my years of living, I'm 12 years old, I have never once seen a waterbed in real life. Are they real? I don't know. I don't know anybody who knows anybody with a waterbed. Do any of you in the comment section have one? Can I try it out, please? Anyway, we'll discuss that later. Next story. So, I was a medic in Israel, and most of the time I was on a special ambulance for extreme emergencies or dangerous runs. After an overnight shift with that one, I overheard that one of the morning shift medics didn't show up for a regular ambulance, so I offered to take his spot. Well, I didn't realize at that moment that the driver and the other medic were both very orthodox religious, but when I did, I said whatever and went with them. On the ambulance, there's a hierarchy, and in this one, I was on the bottom rung mostly because I was only 18. We then get a call for an unconscious woman at a bus stop. We get there, and it's a visibly homeless woman who's not breathing, has a very weak pulse and a locked jaw. I think in this case, you're supposed to break the jaw open to the airway, but the other two refused because they were men and she was a woman, and they physically stopped me from intervening beyond trying to tilt her head back. So we watched her die and called the coroner and took off immediately after they arrived. I stopped working with them immediately afterwards and went home. The next day, I filed a complaint, but it wasn't taken seriously other than I wasn't allowed to be on their ambulance again. I'll never forget that call. Next story. I worked as an OR porter for a number of years to help me through school. I was cleaning up after an operation on an inmate who was Hep C and HIV+, and I was working quickly and recklessly. I stuffed the blue matting and used aprons into the garbage, and as I pulled up from the garbage, blood was pouring from my hand. Unseen and unknown to me, a doctor or nurse had left a scalpel in the blue matting. It was so sharp that when it cut me, I didn't even feel it, but I was bleeding profusely. The nurses and doctors jumped on it right away, cleaned and prepped my cut, and got me on special meds right away. I had to get shots and checkups regularly for the next year, but luckily, I was okay. What I learned? Work slowly and/or carefully, especially in high-risk situations. Complacency is your enemy. Next story. I was a final year student at an overseas hospital working in a few busy trauma EDs. Patient came in complaining of pain in her lower leg, past medical history of CCF and T2DM. Then 2 days earlier, she had been in after a fall at home, been sutured and sent home. I examined the patient who was stable, with pain out of proportion. I undid the suturies and serious fluid came out. I ordered a US which showed no DVT. I discussed the case with the registrar but did not ask for them to review the patient. They advised discharge with oral antibiotics and simple analgesia. The next day I come in for morning round and find the patient tubed in on an antitropic support. My heart sank. I pulled back the sheets and saw gas locals halfway up her thigh. Patient was taken to theater, had a hind quarter amputation, and sent to the ICU. I left the next day and didn't get to follow her up, but passed away. Pain out of proportion terrifies me. I've stopped calling people wimps or hypochondriacs. They get Imagine, Ortho Review, full bloods, etc. I recently x-rayed someone's leg looking for gas. It will forever change my practice. Though the yield on these extra investigations is likely small, and one day I'll find an incidentaloma. Next story. I was in nursing school and several of our clinical rotations were done at a subacute long-term skilled nursing facility. There was one patient there who was an old 80. She was in the SNF because she'd just had her second above-knee amputation. She had multiple bed sores, CHF, horrible diabetes that she never controlled, hence the amputation, everything. A classmate and I were changing her brief and doing some simple wound care on her coccyx. I was holding the patient over to my side of the bed. She was very weak and not much of a help holding the bed rail, while my classmate cleaned her up. The patient started grabbing frantically at me, though. She had a history of anxiety. So I soothed her as my classmate finished up. We laid on her back and elevated her head so she could catch her breath before I did my side. She seemed more at ease and let us finish up, but as we were leaving the room, she coded. This SNF was so small that most of the doctors only came in once a week, and none of them answered their phones to give orders during the code. So the nurses and a respiratory therapist ran it. Her intubation was traumatic, with blood coming out of her mouth. Her ribs were broken during CPR. That's how her daughter saw her. She never came back to consciousness. It was my first time talking to a family about DNR and what they wanted us to do to keep her alive. The daughter signed a DNR about 36 hours later, and the patient was gone the next week when we were there for clinicals. There wasn't a mistake per se, but now I'm a lot more in tune when my patients try to get me to do or not to do something. Even if they don't know the reason for it, there always is one. Next story. Med student here. A few years ago, when I was working as a medical assistant in an interventional pain management clinic, I was asked by the doctor to place a grounding pad, a sticky pad like they use for EKGs, on the patient's leg during a radio frequency, RF, nerve ablation procedure. The patient had some lotion or something on her leg that was keeping the pad from sticking properly, but it seemed to be mostly well attached, and I didn't want to hold up the procedure to get another pad or clean off the patient's leg. Well, the pad ended up partially coming off right as the high-voltage RF was being applied, causing a small burn on her leg. There was no lasting damage done, and the patient was very understanding, but I still felt horrible. It was the first time I had caused harm to a patient, and it could easily have been avoided had I just spoken up. Now, I never hesitate to say something if I have even a slight feeling that something is off. Nothing is more important than a patient's well-being. Next story. I'm a respiratory therapist and work most of the time either in an ICU or the emergency department. This one time, we had to resuscitate a patient who coded or cardiac arrested. I can't seem to remember what was the cause. Due to me being CPR, I displaced a few ribs of the sternum, which is common, but also managed to nick an artery, which is bad. The code team was wondering why the patient cannot sustain his heartbeat, and you go through the possible causes, what we call the H's and T's, mnemonics, why they cannot obtain a good pumping heartbeat. The doc got an ultrasound reading off the chest, and true enough, the patient was bleeding like gangbusters. The whole inside of a chest cavity was soaked in with blood, what we call a hemothorax. And CPR made it worse too. The doc stuck a chest tube in to drain the blood while we kept on resuscitating the patient. The bleeding also didn't look like it was going to stop anytime soon, so a cardiothoracic surgeon had to find out where the bleeding was coming from. Eventually, he died a day and a half later. Granted, his chances for meaningful survival were slim to none because his brain was starved of oxygen for a prolonged period of time, but his resuscitation effort was needlessly complicated by internal bleeding. No thanks to me. Next story. Kind of humorous. I'm a nurse assistant, formerly worked in hospital with chemo patients. One day, I was in with a client/patient getting the room back in order after his morning bed bath. I'd already put away all of my supplies and had an armload of soiled linen about to leave the room when I asked if he needed anything else. He said no, he was fine. Well, not skipping a beat, I say, okay, I'll just get out of your hair then. 50 shades of blush. Let's just say we were both shocked at what I had said, but he made a joke of it along the lines of, I don't have any to hold you back, and I made sure I caught myself before it happened again. Next story. I am an internist. I will never forget the time I was an intern and had one of my first patients who was profoundly neutropenic, rigoring, and hypertensive who ended up crumping big time. Several lessons I learned from that. Neutropenic patients can decompensate in a matter of several hours. If a neutropenic patient looks sick, trust your gut, even if you can't find the exact source. Should have given gentamicin sooner. Next story. In 2 years of clinical rotations during med school, I had encountered a patient, we'll call him Bob, many times. Everyone knew Bob. He had spina bifida with lower body paralysis that also led to many other problems. Despite his poor lot in life, he was always really optimistic and cool about it all. Even when cleaning out a rectal ulcer for him, one of the worst smells I've encountered in my life, he was still able to joke around and make the procedure no different than applying a Band-Aid. Eventually, Bob had signed a DNR order and requested no further surgeries. He was mid-20s and just tired of all of the procedures. Anyway, I was on a 24-hour call when the nurse paged me to come check on her patient, and sure enough, it's Bob. We know each other by this point. Say hi, then I see that one leg is purple and twice the size of the other. Obvious blood clot and occlusion. I go wake up the senior resident on call, we rush to Bob, we call the surgery resident on call, and they start prepping for immediate surgery. We hurriedly talk Bob into consenting, which he reluctantly does. What we didn't do, though, was call his main doctor, or slow down to actually talk to Bob, or notify any of his family. And that fact haunts me years later. Bob did not wake up from the surgery. His family and his doctor all arrived at the hospital that morning to find him not in his room, but in the operating room. He died in exactly the way he had decided he did not want to go, and no one got the chance to say goodbye. Everything we did may have been medically correct, but that doesn't make it not wrong. We were all new doctors so eager to save lives that we never stopped to wonder if we were saving the person. I wish I could tell his family I'm sorry. Next story. I am an RN. Throughout the school, they drilled into us the importance of quality nursing. You are the last line of defense to catch an error. You, not the doctor, are the primary coordinator of patient care, etc., etc. But still, in my first months of work, I downplayed my role and maybe expected that the MD would always know what he was doing. What I learned later is that every day, I have 4 to 5 patients to be concerned with, while my doctor has many, many times more than that. Where I work, in a small critical access hospital, the doctors have those they admitted to inpatient while simultaneously managing their clinic patients, primary patients, OB patients, and some do 48-hour ER shifts as well. They simply can't be attentive to everything. We had one patient who stayed with us for weeks. Initially admitted for lower extremity pain and weakness, he had undergone physical therapy, been worked up for fibromyalgia, had been aggressively treated with painkillers, and only seemed to be getting worse. I was concerned that he was beginning to show signs of delirium related to the Norco he was taking, and I relayed this to his doctor of the time being. Doc ordered around-the-clock ibuprofen to supplement his analgesics and increased the duration between Norco doses. Later, he was switched on to Mobic, longer-lasting NSAID that requires less frequent dosing. What the doctor never ordered, though, was a GI prophylaxis. He was receiving daily doses of strong drugs that can cause GI bleeds and got no drugs to counter that effect. When the patient changed hands to another doctor, the doc did a thorough workup and finally found what may have been most likely the cause of his symptoms. The patient was experiencing spinal stenosis, enough to pinch his lower spinal nerves. Doc number 2 immediately ordered Solumedrol, a very powerful IV steroid, twice a day for 5 days. Unfortunately, he did not perform a thorough medication review. He did not realize 1, how long he had been on Mobic, 2, how frequently he had been taking ibuprofen and for how low, and 3, that his GI system was not protected with Prilosec. Of course, he didn't know all of these details because, as I know now, it was the nurse's job to snoop out these problems and present them to him before harm could be done. The rest of the story is gritty detail, and I'm a bit tired, so I'll just summarize. After a few days of Solemdrol, my patient developed a severe GI bleed. He was found ghost white, covered in sweat, with a BP so low it was unreadable. We dumped him with fluids and shipped him out to a regional medical center, but unfortunately, he didn't make it. Next story. I was a hospice nurse for 10 years. I admitted a patient with cancer who had intractable bone pain, with what I expected to be a week or two before he died, based on my assessment. In his case, the only medication that gave him any relief was morphine. His wife did a great job taking care of him and giving him his meds as we planned. It was very effective, and he was comfortable. As he came closer to his death, though, he was sleeping more, which is normal and expected, and a daughter flew in to be with him at the end. But she went ape crap that daddy was on morphine and raised so much hell that his wife freaked out and caved to her demands, revoked hospice, and called the ambulance. When he got to the hospital, the daughter told him that he had taken too much morphine, and the ER room doctor gave him Narcan. He came out of it screaming in pain and didn't stop. He stayed in the hospital until he died, and he really suffered. It's been years since this happened, and it's still the worst nightmare of my nursing career. There really wasn't anything I could have done because I spent a lot of time teaching his wife what to do and what to expect, but I still feel bad about it. Next story. This was a mistake that my pediatrician made when I was about 13 years old. I had a sharp pain in the lower right side of my abdomen. The pain would come and go and increased with intensity each time. I told him it felt like someone was stabbing me over and over. He then proceeded to tell me it was intestinal cramps and did not run any tests. Well, I dismissed that pain as intestinal cramps for the next 3 months until one day I fell on the floor and literally could not get up from the pain. I luckily had my cell phone and called my mom, who was at work, and told her what was happening. She picked me up, literally, put me in the backseat of her car, and drove me to the hospital where they ran tests and immediately took me to the emergency operating room because my appendix had burst after being inflamed for so long. I was in the hospital for 2 weeks and bed rest for another 2 at my house. I missed a month of middle school. We tried to sue my pediatrician, but according to my mom, we didn't really have a case because no organs were damaged and I did not die. Needless enough to say, always get a second opinion. Do some research if you are in excruciating pain. Next story. In the end-of-life care, symptoms matter, not the numbers. 21-year-old developmentally delayed kid dying of sarcoma. He never understood death and hated pain. His parents only wanted him pain-free. Night shift. I had poured my heart into his care since diagnosis. He was in pain. He was inpatient hospice due to a need of a continuous fentanyl pain pump. It was at 500 mcg an hour, which is like 50 milligrams of morphine an hour. I went through the process of calling the hospice RN, then had to talk to the pharmacist, who refused to up the rate. And I was irate about it. I asked her to come to the bedside and assess his pain herself. I remember the parents looking at me in shock when I told them I didn't get the order. I could not see him in pain. I upped the pain pump without an order. I went up the chain of command to cover my ass, but there were 6 hours where I was making the clinical decisions myself without any orders. A major FU to that pharmacist for worrying about the dose and not the symptom. Next story. As a paramedic intern, I had one call in particular that still sticks with me. We were called out for an early 40s male with chest pain. We get there to see a healthy guy sitting in his car, breathing hard. I get a history from his wife and an initial assessment of the patient. Doesn't have any history except for having anxiety problems and previously treated for abusing his anxiety meds. The patient described his symptoms as being just like when he was having panic attacks. I hook him up to the monitor and everything looks fine. Slightly elevated heart rate, but all of his other vitals seemed to be within normal limits. I get him loaded into the ambulance and begin the 20-minute transport to the hospital. I start treating him with meds for the chest pain protocol and I start an IV. Then all hell breaks loose. He tells me his chest doesn't hurt anymore, but he can't breathe. His vitals didn't line up with respiratory issues, but I put him on high-flow oxygen just to be safe. As soon as I get the oxygen on him, he starts losing it. He tells me he needs to get out of the ambulance. He starts standing up, ripping all of the wires off of him, pulling the oxygen off, and even pulls his IV out. I struggle with him to keep him on the gurney and calm him down. I start another IV, he pulls it out. I hook him back up to the monitor, he pulls it off. Same with the oxygen. The situation turns into me having to physically hold him down to keep him from jumping out of the ambulance on the freeway. I ended up having to be pretty stern. I was yelling at him to sit down and stop fighting. I gave what little report I could to the hospital, holding the radio in one hand and his shirt collar in the other. All I could tell them was that we had an agitated patient initially complaining of chest pain, which has resolved, and now seemingly having a panic attack. I didn't use the words panic attack because it isn't my place to diagnose, but the description of the situation spoke for itself. I had no current vitals to give them, cardiac rhythm, nothing. I couldn't even get him to keep an IV in. When we finally get to the hospital, we wheel him in, still holding him down. The moment we transfer him to the bed, he goes from an agitated, fighting guy to a full cardiac arrest instantaneously. We worked him up in the ER bed for over 30 minutes. After the doc called the time of death, he came out of the room with us looking confused and said to us, "I thought you were bringing in a panic attack." Well, so did we. To this day, I have no idea why he died or what was wrong with him. I just couldn't stop thinking there was so much more I could have done for him had I been able to manage his anxiety. I was the last person to have a conversation with this guy, and it consisted of me telling him to sit the F down. I had plenty of patients die before and after that, but that is the one that stung the most. I had never felt that helpless and confused before on a call. Next story. RN here. I had 5 patients that night. 2 were being treated for cancer. 1 was responding well, 1 was not. I had looked through the charts briefly beforehand, noting vitals, labs, meds, etc. It was super busy though, so I didn't actually write anything down. I go in to do assessments, and my 1 cancer patient looks so good. She looks healthy and has a great appetite and is on the phone making plans for her daughter's high school graduation. Surely this is the gal who is responding well to treatment and is probably near remission. She then asks me what our CA25 labs are, and I tell her they are much better. I say, yeah, I think they're in the 30-ish range, and she immediately yells, "Oh my god, what?" and starts to cry. And I get nervous and say, here, wait a minute, I may be confused. Let's just look into your chart together. I log into the computer in her room, pull up her labs, and boom, her CA125 is sky high, and much worse than it was at her previous draw. I tell her the actual lab results, and she says, "I knew it was too good to be true," and starts sobbing for real. This woman is 45 years old and effing dying. I apologize profusely, and she is so goddamn gracious about it, telling me she knows she's dying, that she knew the moment I said it that I couldn't possibly be correct. But as she said, "You just never give up hope, you know? And I just wanted to believe so much that I might live long enough to at least see my kids to adulthood." And then I end up bawling and puking in the bathroom several times that night. I have never before or since cried at work. I'm not a person who cries much. And for those of you who don't know, CA125 is a cancer marker that is one test used to measure the body's response to certain cancer treatments in some cancer cases. So, no one had gone over her test results with her yet. Because they were so horrible, the doctors were conferring about whether to withdraw care entirely or whether to try and limp her along until graduation, knowing that further treatment was hopeless, expensive, and probably not going to buy her more than a couple of weeks. And she died 2 weeks later. She did not live to see her daughter's graduation from high school. So now I will never ever give results I'm not sure about. I will never ever make a statement that I can't verify to a patient. I'm still horrified by the anguish I caused her with my careless comment, and it has stuck with me for years. Hell, I'm tearful and feel like puking right now from typing out my confession. Next story. I am an EMT, ending my first year working at a collegiate EMS squad in New Hampshire. Our dear colleague is known for drinking and going a little too hard in the party department, although we're smart cookies too, I swear. So, although we get a good amount of trauma/other medical from sport events and other crap just responding to the town the college is in, we get a whole lot of intoxication calls, as you'd expect at most colleges. Anyways, once I got a call that seemed like a standard intox. Our female patient was really embarrassed we had been called, as remorseful drunk people often are, and was really distraught and crying. She refused to speak to me or to my 2 crew partners. We at least got a full suite of vitals that were all normal. I then went to put her shoes on to get her ready for transport to sleep it off at the college's inpatient department, and she refused to let me touch her. Picked out only the female EMT out of the 3 EMTs and the 3 college security officers there, and said she only wanted her to help her. So the males in the room stepped outside for a second because at that point we were a little suspicious. This girl was also leaning against her own bed and didn't know where she was, how she got there, or what time it was. She at least knew her name, but CAOX1 is pretty low for intox with the severity she was presenting physically. chemically and physiologically, and when we had a straight line, she walked it almost perfectly. Also strange. Then, she told the female EMT she felt safe and didn't trust us, which we of course heard in the hallway through the open door. Thank God drunk people aren't good at whispering. It would make my job a lot harder. Once we transferred care, the only follow-up we got on her was that it was a probable SA, which was on my mind after the call ran its course, but didn't occur to me immediately. It was the first possible SA that I had been called to, and it kind of disturbed me seeing this girl just effed up out of her mind, crying hysterically, and saying she felt bad that we were called, and then not trusting the people who were there to help. SA can really destroy people's trust and make them anxious beyond rationality. After that call, I go into every scene looking for signs of SA or abuse. Honestly, most college campuses have a problem with it, and it's so often related to alcohol. I should have probably been more prepared to deal with it, but I'm kinda glad that call kinda woke me up, so to speak. You never know what might have happened to your patient that they didn't want to tell you, and that's a lesson that's generalizable to calls beyond college and alcohol. Next story. Other side of the coin here, not the doctor, but the patient. 5 years ago, as a 45-year-old female, I stopped being able to have a bowel movement. I have always been regular, set your watch to it kind of regular. After the first week, I go to my doctor, who of course tells me to take stool softeners, etc., and sends me home. Next week comes, and I'm back in with pain, and he gives me the same answer but adds in an enema. No help. And what's really bothering me is that the enema comes out as clean as it went in. Over a period of a month, I see the doctor 5 times. The last time he orders an x-ray, sees nothing, and sends me home. I haven't eaten more than a few rare bites of food for days, losing weight. My husband is now freaking out and demands a CT scan. The doctor complies, and I go in. The tech does the scan and after pulls my husband aside. He tells him he can't diagnose me. He's not supposed to say anything, but he tells him to take me around the corner to the ER and refuse to leave. By this time, I can't walk. I'm in too much pain and I'm too weak. My savior of a hubby grabs a gurney and takes me over to the ER though. A nurse tries to tell him he can't have the gurney, and he tells her what's going on. Within minutes, it was like I was the only patient in the ER. Those people were incredible. They dotted on me, and I always had someone by my side. Within hours, I was having emergency surgery for stage 4 colon cancer. Apparently, my doctor checked in once while I was in the hospital. I was pretty drugged up and don't remember. Next time I see him, it's 2 years later. I've been through chemo, had my bowels reattached, and seeing him because during my second stay in the hospital, I contracted ringworm on my back. Then he asks me what all my scars are for. Are you effing kidding me? You completely dismiss my symptoms. I lost 20 pounds in a month, down to 102 pounds, in pain, and had not taken a crap in weeks, and you can't remember you effed up? I don't expect you to remember me by looking at me, but you have an effing chart in front of you. And that was my last time seeing him. You would think a lapse in care like that would have given him a wake-up call. Guess not. So there's something that's been on my mind for quite some time now, especially in dating, but also just in general. But that my mindset is half of the human population is the opposite gender of you. Wouldn't you want to better understand half of the human population, at least to some degree? And one thing I've learned over that time, just sitting, listening, reading, watching, is that women and medicine just get ignored a lot. Like, walk it off, forget about it, you're hysterical, it's not that big of a problem. And I guarantee you, if we did a video like this where it's from the patient's perspectives or like medical things that went wrong with you, we would get a lot of those stories. So it's really unfortunate that women have to go through that. As for me, I'm not in the medical field, so I can't really do too much on the matter. I can't really change my behavior towards it. I just offer sympathy because I think that's really unfortunate that you say I have pain and the doctor says, no. But anyway, next story. ER doctor here. Not my mistake, but one made by a colleague who handed over a patient to me. When doctors do eventually get to go home, we usually hand over patient care to a colleague. Handed over information is often reliable from reliable colleagues. I was handed over a 50-year-old man who'd been picked up off the street at 8 p.m. after he'd been out drinking heavily all day. He was accompanied by his friend, who said that he had, in fact, been drinking heavily for several hours. He had further said that they had been staggering home when the patient had staggered off sideways and ended up in a bush. My colleague had seen and examined this patient and handed over to me that he was heavily intoxicated, and that he had asked security to come and assist him to the front door in an hour or so. It was all sorted, he said. Nothing to worry about, he said. I was busy in Rhesus with 2 patients trying to die on me, so I figure, what the hell? If it's all sorted, that's fine by me. me. This sort of thing is common, especially in the middle of a Saturday night. A couple of hours later, I am sat writing up my notes when I see the same patient wheeled back in by security. "Hey doc, this guy isn't right." "What do you mean?" "Well, we took him out front and stood him up and he just kind of keeled over and hit the deck. This guy can't walk, never mind go home safely." "All right, fair enough. Bring him back in and I'll see him again." So they put this guy in the room he came out of and I wandered over to take a look. The booze is coming out of his bones. Eye-watering stuff. I say hello and give him a shake. He opens his eyes, nods, but says nothing. After a few seconds examining him, I realize that he's not moving his right arm. Then I notice that he's actually not moving his right leg either, nor is he answering any of my questions. I do a full neuro exam. This guy's having a stroke. CT and blood panel later, and he's being taken to the stroke unit. And I learned two things from this patient. One, never trust information that is handed over to you, no matter how skilled your colleague. 2. Never ever assume anything. Yes, he was hammered, but he was also having a stroke, and the clinician who saw him first let the alcohol literally cloud his judgment. Next story. I was a third-year medical student on my surgery rotation at Cook County Hospital back in the mid-1990s when I was still in the old building. It was a chaotic mess. I was post-call and in clinic and saw a patient who had some type of intra-abdominal procedure and was in for follow-up. He lived in a trailer park on the far south side of the city, was poor as dirt, and clearly wasn't thriving post-op. He was dehydrated, and we were concerned that he had a ileus. Bowels weren't moving. I was told to admit him. I told the transporter to take him over to the surgical ward, but somehow forgot to write admission orders, so he went over with no paperwork. He ended up getting put in a bed and stayed there for 3 days with no paperwork. He got IV fluids and bed rest for 3 days, but because no admission orders went over, he never got entered into the computer system. He never showed up on our list of patients. The nurses just kept changing his IV fluids. He had no vitals, no nothing. Well, 3 days later, we were on rounds and walked past his cube. It was an open wall with cubicles at the time, and my senior resident stopped and said, "Who the hell is this guy?" The patient poked his head out, pointed at me and said, "Hi doc, when can I go home? I feel great." He was completely better, probably because we did nothing to him. My junior resident whispered to me that I should just quickly and quietly write up admitting orders and discharge orders. So, 2 lessons. 1, always do your paperwork/orders right away. 2, sometimes the less we do to and for a patient, the better. Okay guys, I think this story admits to us that if we just ignore it, don't even Google our symptoms, take a nap and drink a little bit of water, all of our problems will go away. Financial, medical, romantical. Anyway, next story. Pharmacist here. I was working alone on a Saturday. Just before closing, a woman brought in 19 prescriptions for her husband who was just discharged from the hospital. Then a swarm of people came in after her, and I kept getting interrupted by people who refused to wait until the next day for their Xanax. One of the prescriptions was for a heart blood pressure pill. It was written for half a tab daily, and I filled it with instructions for 1.5. It was a normal dose that I saw often and was well within the dosing guidelines, but it was too much for him. Several days later, he was readmitted for low blood pressure, and the prescribing physician caught my error. I called his wife to apologize for my personal number as soon as I found out. She was so understanding. She saw how crazy things were for me and understood how stressful the situation was. I offered to pay for the out-of-pocket costs of the additional hospitalization, but she would not accept. Unfortunately, he was a very sick man and died 2 weeks later of issues not related to my error. It could have been much worse, but it really made me realize that I hated retail pharmacy and the lack of help that put so much strain on pharmacists. I quit as soon as I found another type of pharmacist job, and I am so much happier. It haunted me for a while, but I was able to get over it. Next story. This will probably get buried, but I was a pharmacy tech in a woman's hospital years ago. We had issues in the past with labor and delivery not returning their unused narcotics they signed out for a patient. We had strict guidelines that would be written up if meds were not returned properly. I was on break one day, and this young new nurse sits down beside me and starts crying her eyes out. We had never met before. She decided to unload and told me how she forgot to put aside the unused narc that she used and threw it in the sharps container instead. I told her I work in the pharmacy. It was okay, mistakes happen. As long as she had her trainer vouch for her, we could just deal with it on our end. The pharmacist just needed to be called. Then she tells me she wishes she had known that an hour ago. Her trainer made her go through the sharps container and bloody placenta-filled sheets and things to find this small 2-milliliter bottle, which was put in return for the pharmacy once found. I was floored that someone thought that was a better idea to expose her to that instead of just calling the pharmacist to ask what to do. That poor girl had such a crappy, dangerous first week of being an LDR nurse. I wonder sometimes if she stayed in that career. Well, folks, we read through all the stories and probably maybe some of you got a little emotional at times. Yes, these are trained medical professionals, but they are also human who make mistakes and need to learn things over time, just like we are in all fields of life. And I am certainly not letting AI diagnose me. No way, no how. But anyway, folks, feel free to comment what you think on the video. Thank you all so much for watching, commenting. Have a really good day, and bye-bye.